everyone. Hi, I'm letting you trickle in here while we get started. Welcome to Lifecare Planning 101, presented by us here at Injury Institute, your premium medical provider network on liens, providing the best concierge medical scheduling services for personal injury attorneys and their clients for over 25 years. We would also like to thank our sister organization, the San Diego Injury Network, with Jennifer Evans Wong, for helping us put together this webinar for you today. We have a wonderful panel for you, and our moderator, Attorney Robert Hamparyan of Hamparyan Law Firm. He is one of California's most active and successful trial lawyers who has obtained numerous seven-figure jury awards and countless accolades for the legal community. His practice focuses on catastrophic orthopedic, spinal, and brain injuries, as well as wrongful death. He is joined by Dr. Hirsch Kavishvar of Synergex Med, a double-boarded physician in general neurology and interventional pain management. He is currently seeing PI clients out of his Long Beach and Beverly Hills office locations. Dr. Kavishvar's areas of expertise include evaluation and treatment of back and neck pain, headaches, migraines, traumatic brain injury, concussion, musculoskeletal and arthritis disorders, cancer pain, neuromodulation, and acute pain management. We are also joined today by Dr. Mark McDonough of San Diego Neuropsychology. With a doctoral degree in clinical psychology and a health psychology emphasis area, Dr. McDonough focuses on neuropsychological testing of children and adults, toxicity, traumatic brain injury, and psychological assessments. Then we have Brooke Furick of Furick Medical Planning, a life care planner and registered nurse for over 30 years. Of Coast Injury Care Center, we also are joined by Eliana Rubin. As the facility owner, Eliana has a lifelong commitment to providing the highest quality subacute care, post-acute care, and rehabilitation therapies to individuals who have been catastrophically and severely disabled. Then to complete our panel today, we have Marjorie Smith of Sage Settlement Consulting. As a certified financial planner, and licensed financial advisor, Marjorie considers all options for how settlement funds may be maximized and coordinated with all aspects of a client's financial life. So with that little background, introducing our speakers, I will hand off the mic to Robert to get us started. Robert, take it away.
Thank you. Good afternoon, everybody. Thank you, Ms. Whelan. Appreciate the intro. If you can use your sharing of the screen with me, Ms. Whelan, so I can put that up. Are you able to?
It should be already good to go. It's shared with all panelists.
All right, fantastic. Then let's go with that. So I guess the topic of what I'm supposed to be speaking or leading with today is what we need to accomplish to get and present future medical needs to jury in medical cases, such as ones where it involves mild traumatic brain injuries and such. And 26 years or so that I practiced in the personal injury arena, defense and plaintiff. In the last 15 or so, I've been able to handle and try a number of brain injury cases. And from what I've learned from my own experience, the successes and the failures in those areas, I want to share those with you. So as a caveat, I want to give you that no two cases are the same. No two trials are the same. And no fact patterns of any kind are ever the same. So if I give you a general overview of what I do, you're by all means free to change it up, change the order, modify things, or do it differently. And obviously, I'm always available for questions and answers after the fact. And you can call me on at any time, call the office, and I'll be happy to explain things and answer any of your questions later. So when I'm dealing with a brain injury case, whether it's mild traumatic, whatever they want to call it, traumatic, anywhere in the middle of it. Generally, I go through a list of things in the beginning. That's the macro view of the case. I look at the case and I look at my client's injuries and I have a list of those injuries. Generally speaking, any case that has something with a traumatic brain injury, 9 times out of 10 has other injuries, orthopedic and such. So I list those after looking at the case and looking at the medical records, just so I can have an idea of where I'm going with my experts, what experts I'm getting, and why I'm getting these experts. You have to have a purpose before you get into it. As far as your client's concerned, it's as if you're walking into a store without a list of shopping items. You're going to be all over the place and not know what to get. if you have a list and you know where you're going with it, you're probably going to be more organized and get the shopping done properly in a quick and reasonable manner. Within the list of injuries, I also look at the records to find what care was provided to date. That's also important to give me sort of the baseline of where I'm starting. If it's a case that I am looking at a few months down the line or within a few weeks, it makes a big difference. Getting the records immediately and finding out what has happened from the time of the injury till the present is very important. Likewise, looking at the providers and the folks that have treated the individual that's injured, my client, is also very important from the initial outset of looking at these cases because, as you all know, some groups, some medical providers are a little less apt to help and cooperate in the litigation part of your case. I put the name of Kaiser first and foremost, not because I don't like Kaiser. I'm not going to share my personal feelings about Kaiser, but because generally speaking, when dealing with Kaiser providers or Kaiser care, you're going against a lot of push from the beginning, whether it's getting the records, getting cooperation of doctors, getting to testify in depots, even their SOAP notes, generally speaking, when they realize the client has a pending litigation matter, all of a sudden you see a different sort of narrative in the way they describe the care. And I would definitely like to hear more from you folks on your experiences with Kaiser, but that's been mine. On the other hand, if you have PPOs of private providers, et cetera, that are the doctors or primaries that have seen your client for years or seen a client for years and continued care afterwards and directed the care after a traumatic injury, then it makes it a little easier for all of us, including the lawyer who's handling the case, to figure out what to do with that. I've used this term, a plaintiff's team, because when we're dealing with an orthopedic or traumatic brain injury case, we work with the various doctors, professionals, life care planners, folk rehabs, as a team. And I draw that from my prior experience in sports as a kid. To learn to play on a team is really important because it gives you an understanding of the need for everybody to cooperate with each other to get your client's goals as far as moving the case forward and getting the success that he or she deserves as far as her case. With the example of a traumatic brain injury case, generally speaking, I rely on a few experts just for the medical portion to prove those future damages. And this is obviously without consideration to the biomechanical engineer, the accident reconstructionist, those folks that you probably need to prove the liability picture. I'm just talking about the damages and focusing on mostly the future damages. To that, generally, without a special order, I usually utilize a neurologist, and we deal with neuropsychologists, physiatrists, an orthopedic surgeon, a vocational rehab specialist, a life care planner, and an economist. They each have very specific and important roles in putting together the puzzle that for a group of jurors that are going to try and determine what the damages are, they may have a hard time organizing their thoughts. So we have to do the organization for them. And when it comes in these pieces and when it's coordinated properly, the jury sees the picture better and they can hopefully give you the damages that your client deserves, and they can give you the full damages that he or she deserves in the future. To these experts that I am referring to, obviously we know their roles. You've heard of every one of these folks in the past, and they're not new specialties that I'm talking about. And most of these folks are going to be talking today, given the presentations about future damages. So you'll learn more about their areas of specialty. But with respect to how they work together to get a damages plan put together for the jury on a future case, I'll be elaborating some more on how we get these folks together and how we incorporate them at the time of trial. I mentioned in one of the slides that you don't have in front of you to get all you can from your experts. I don't mean that facetiously or to be flippant or to sound like I'm asking for something I shouldn't. When you have experts designated, professionals that come from various fields, and they are there to help you out in order for you to get the most out of them for your case and for your client's case, you have to, as the trial lawyer or the attorney handling the case, give them all the tools that they need. Give them the key to the car, hopefully show them where to go so they can take care of it for you. And that's no different than a TBI case. And it doesn't really matter what type of case it is. The more significant the damage is, obviously, the more experts, the more you have to focus on coordinating these folks. And it's not so much that you should play as the quarterback, you're the lawyer. I think the role of a quarterback in these cases and the future medical damages cases, I generally, my Lifecare planner and the physiatrist to do the quarterbacking. I asked the physiatrist and or the Lifecare planner to work together and contact the neuropsychologists, the neurologists, the orthopedic surgeons, the voc rehabs, and talk with them, give them the updates on what the client's needs are as far as future care is concerned, ask them what the needs are from each one of their perspectives, and get that order filled out so we can present it in a very organized way. When I'm dealing with experts before trial and months before trial, I usually try and do some of the stuff that we have to do. And I'll be happy to provide the slides later. It's not that crucial, I think. So what I provide the experts will not obviously work all the time, because it's the medical care that the patient and the client is receiving is dynamic. It's not static. It doesn't stay the same for most clients, especially with the ones that have TBIs, especially the ones with the complex orthopedic injuries or the multi-injuries, orthopedic and brain, etc. They undergo different things, whether it's follow-up care, the surgeries, the psych evaluations, the medications that go up and down to primary visits, etc., and PTs, OTs, all that stuff. So getting the experts their records is something easy to say initially, but we have to do that. And I've, in the outline and the slides that I have, I put down the 4 brackets of what I have to do to provide my experts the things they need. And number one and the foremost is all medical records. Cost is always an issue to discuss, and cost is always a concern. But if you are handling a TBI case and if you want the maximum medical futures, the most important thing that you can do as a lawyer handling the case is provide all of the records. Your expert's at a clear disadvantage when he or she does not have all the medical records. And when I say all, I am relating medical records predating the accident and going forward. And I usually relate back about 10 years. Because what the defendants do is they'll subpoena the same records, and they'll have those same records, and they'll actually provide them to their experts generally. And I've seen that over all these years. Your expert now gets handpicked records for your client, and he will, or the expert will do, or she will do her best to provide opinions based on those. But you're leaving your expert at a disadvantage when compared to the completeness of the other side's evaluation. No reason for that. You may be saving a few $1,000s, and I'm not taking that lightly, but the damage done to your expert's credibility is going to be enormous. So what you save in the beginning on the few $1,000s in record reviews will cost you more on the damages part in the future. And I've seen that over and over again. When we see the defendants cutting corners, it helps us tremendously too. When they don't give all the records, they don't provide the depositions. it goes both ways. So I'm just sort of focusing on that because it's really important. And in line with the records, I also try and find all the diagnostic films, the MRs, the CT scans, the X-rays, whatever is available that was provided or for this particular client of yours. I get the records, the reports, but also the films, and I provide those films to the neurologist, to the proper experts, obviously the medical experts, the Lifecare planner, if with a nursing background, like one of our experts who's going to be presenting today. They need to know these things. They need to have some kind of an input on that, and the more you provide them, the better off everybody is. What we also can provide, and I do provide my own experts in cases, the access between them and anybody that has taken care of my client, be it the experts that are also from the other different fields. For example, if I have a neuropsych, if I have Dr. McDonough, and I have a neurologist, and I have a nurse life care planner, I would love for all of them, and I insist on all of them talking to each other at least once, if not more than that, to get a gauge of what is needed to orient themselves on what they're going to be able to say and not say. And I'm not saying that in some sort of cliquey plaintiff versus defense thing. I'm just saying that they're there to help you out, and so you shouldn't be the hearsay person communicating what one doctor expert said to another. Instead, just open the doors, provide the numbers for all experts to talk to each other on your side, so they can help you and help your client and patient. And sometimes I actually reach out to my own experts if they know the physicians that were the treaters, just to pick up the phone and call them and ask questions that I can't answer, and sometimes the client can't answer. So if the client can't answer it, or their memory's not helping out because they've got a brain injury, by all means, why don't you just have the physician who's a colleague of another person perhaps in town, they have an amicable relationship, why don't they just talk to each other if that is possible without asking for any favors? We're not doing that. We're just asking for explanations and clarification on issues. That comes in handy when, for example, you have your expert, the neurologist doctor, being deposed, and he's asked, well, what else have you done? Well, I've looked at the records, I've examined the client, and I also spoke with the physician. Boy, that's a big deal. That goes in a lot better for your client, and it weighs in heavier at the time of trial, because not only is your expert doing his best to assess the situation, he's digging deeper to have any of his questions answered and see if he and the treating physician are on the same page. The examination of your client is very important, and it happens almost all the time in the TBI cases and the significant injury cases. In the cases that I have, they are seen by the experts. I insist on them being seen by the experts. Even if it's a voc rehab, they've got to do the testing. A life care planner, they have to do their examination contact, and if they need to test in some way. So those are folks that I would like to have the client be seen by at least once, and I insist on more than once in most of them. More so at the end of, obviously, the time when you're going to go to trial. It's really important to have your experts see these clients right before trial, or a couple of weeks, a month or so before trial, to have, again, a baseline. And you can, again, differentiate your side of the case from the defense side of the case by showing that your experts not only looked at records, and unlike the defendants, you've seen the experts and the doctors that you have seen the client multiple times, had facial interviews, visited with him or her, understood what's going on, tested them, examined them, and such. So that helps you out a lot in proving your case. I mean, that's ultimately what we're talking about. How do we get damages? The big picture is, how do you organize a case to get the most out of it, to get the most amount of money out of it for the future? And only with these small, very, I guess, common sense things that you could do would you be able to do that, in my humble opinion. One of my other headings was proving future medical damages at trial, which is what we were segueing into. And that goes to connecting the dots for future medical damages. And connecting the dots in a case goes to what we started with, and we need to know what has gone on with your client before the incident to the date of the incident, and going back about 10 years of his or her medical history. If your client had a long medical history, it would be a consideration to probably think about getting a longer period to take a look at it. I've had clients with medical injuries, but a history of collateral things like maybe PTSD or depression, etc. And if the client tells me he or she has suffered from depression for 20 years and now you've got a brain injury, well, the onus is on you to make sure that your experts have those records clearly for a while before the date of the loss, so they can make some sense and differentiate the nature and type of this accident and the injuries from it from those that were pre-existing, or the ones that could be attributed to being a part of the damages that the defense may want to play games with. And then the other part of the connecting of the dots is taking a timeline from the date of the incident and moving forward to the present. And that's again important because that's what happened from the loss to now, and you're a month or two away from trial, and you want to know what those records show, how the injuries progressed or how the injuries changed your client's life. And I think only when you put these parts together would you be able to focus on the present needs that your client is going through and what he or she has to have presently, and then forecast that into the future with the help of your own experts. So these small steps, I think, are very important to have the jury see the evidence instead of just listening to people talk about them. Talking about them is great, but they're going to have folks that are going to do the same. So I think with the vast amount of information that you're providing, with the vast amount of records, with the vast amount of examinations and the interaction between all your experts on a TBI case, you'll be able to prove those damages a lot better. One of the last slides that you're not seeing, unfortunately, is another very simple slide that outlines the things that we need as trial lawyers to accomplish in getting the future medical damages. And it breaks down to four basic things. One being that you have to have this case and the facts and the evidence as simple and as clear as possible. When I say that, I'm trying to perhaps give an analogy of understanding and digesting a case from a jury's perspective. I've seen jurors, and the way they've listened to cases and what they've said in the end has always helped me understand and do better at presenting a case. And the jurors are more like the children that will get confused by facts that go back and forth in time, such as a story that's being told that goes forward, backward, and it doesn't have any chronology. They like a chronology in the case. So whenever you can organize your case with damages from past to future and kind of show how the progression has been, they understand it better and it sits in better, and they will probably be able to understand you and accept the damages that you're asking for if they obviously are in line with logic and the medicine that's been provided by the doctors. The other point that I have that I kind of walked into by talking about making it simple and clear is a chronology. That is the basis for every case I try, and I usually have my come in if I can. And there's always a trick to that because it's hard to coordinate experts at the time of trial. They have their professional timelines and their ability to come out and testify versus taking care of their own patients and such. But when I can, if I can, I try and organize my trial lineup for the damages to start from possibly the most basic background information, the primary care physician, if he or she's available, then an emergency doctor or the physician that saw your client for the specific injuries that he or she had, and then moving on to the expert. And this is obviously if you have these people. I'm not saying every case should be the same, but then moving on with, and then the primary obviously talks about the pre and post if he or she has that type of information, the care treatment that he or she provided pre and post and the differences. And then you bring in your niche experts, the neurologists. The neurologists would definitely come in, orthopedic surgeons to come in and explain what is going on now and how they've compared that to the past, and it doesn't really bear anything with the past and what your client needs now in the future. And the VOC rehab and the Lifecare planner, the VOC rehab usually comes in before the Lifecare planner for me. I like that because it sets the ground rules for what he or she tested and what he or she saw that your client can't do because of the injuries that they have. The life care planner usually is the wrap up for me on a case when they come in and talk about all the things that will be needed, and sort of they put that context of the damages for you, and then you'll have the economist to put it all together for everybody and the dollars and the so yeah, that's essentially what I do in almost every case. There are a couple of things I try and bring in. One of them is a day in the life of video, if and when possible. I have sometimes cases where the clients are in such bad shape, they're either unable to move around, take care of themselves, feed themselves, etc., bedridden, really bad stuff. If you can capture that, and if it's not done in a distasteful way, and I'm talking about, you don't want cinematic, theatric stuff going on. You want it to be as black and white. You want it to be as clear and clean. You want it to be not, I would call it, don't make it sappy. The truth is what it is. And I think the jury's very smart to figure out a person who's struggling with life. If it's being able to brush his or her teeth to washing her face, they're going to see that. You don't need music in the background. You don't. Matter of fact, some judges will not let you put that stuff in. So be careful of that. There is a risk of not being able to bring that in if you do so. But I've also seen that being admitted in cases. Matter of fact, my recall on a very simple fact I want to share with you was a case that I tried many years ago, and that was probably at the advent of these smartphones that we have. And the client was in pretty bad shape. She was a young lady who was unable to feed herself, and she had tremors because of a hemiparesis, brain injury, where she had half of her body sort of damaged, and that was a permanent thing. I wasn't tech savvy, and I still am not, as illustrated by the fact that I can't have this slide put on for you folks. But even then, I think it was one where luck was our biggest help. It was a night when it was after trial. It was the second or third week of trial. We're sitting down, and it was the case in chief for the defense at that point in time. But I was sitting with my client and a couple of my friends from my team that was trying the case, and we're at McDonald's at night because our client liked McDonald's, and she was in her wheelchair and her boyfriend was with her, and she wanted to eat. And generally speaking, the boyfriend was the one who fed her, or one of us would feed her, and she liked fries, and so we had the fries on her little wheelchair sort of tray, and we'd feed her. And that day, when we're talking to each other about what we're going to do the next day, the boyfriend noticed, and I think one of my colleagues and friends noticed, that she was picking up the French fry with her right hand. She was right hand dominant. And the big deal on the defense's side was that she will not be entitled to future damages for rehab, etc., because she's pretty much done. She can't be rehabbed. This is the best that she can do, and she can't feed herself. Therefore, basically excising about a $2 to $3 million part of her damages. Ironically, the next morning was the Lifecare planner for the other side, and it was his testimony that was coming up. And when my friend saw that, I asked him to use his phone and videotape the French fry that she was taking in and putting in her mouth with difficulty, nevertheless. So we used that video at trial the next day to impeach, and it came just incredibly well at the proper time. I think it was God's will or something, but it just happened for her, and that was a huge difference in the damages. For the jury gave her everything that she was asking for, and we asked for. That's an example. I'm not saying that's going to be, the thing you do all the time. I'm saying that a day in the life of is an important tool that many experts can probably use. A Lifecare planner, voc rehab, your neurologist, your physiatrist can help, and neurologist can put that together for you with your help, and you can get to success in getting all the damages. This is probably all I'm going to be talking about. I don't want to take more time than I'm entitled to. I'll probably turn it back to you folks at the end after all the experts and the folks that are going to be talking. And if you have any questions, I'll be more than happy to moderate that for you. I thank you for your time. And I think the good doc will be next, right?
Okay. Can you see and hear me okay?
You're good to go.
All right. So thank you for having me. My name is Dr. Hirsch Kabishavar. I'm, as introduced before, I'm boarded in both neurology and pain management. Just to give you some background about my experience, I'm originally from Michigan, did all my training there. I did my training in neurology at Henry Ford Hospital in Detroit, which is a very, very busy tertiary care trauma center in downtown Detroit. And it has one of the largest neuro ICUs, and there's some pretty big names in traumatic brain injury and neurosurgery that have come out of there and are responsible for a lot of the science that we know about TBIs. Afterwards, I did a pain fellowship, and I did an additional training in kind of mild TBI or in concussions, specifically mostly with athletes, but that's what brought me out to California, and so I've been here since. And afterwards, if you guys have any questions, you guys can check out my website, and my email address and contact information is there. So I'm just my impression was that I was to give a sort of a brief overview on TBI, moderate to severe TBI. I mean, I think, when it comes to life care planning, that's usually what's involved and not necessarily mild TBI. So I just wanted to give a brief overview, the medical overview, and kind of, each one of these things I was telling earlier was that each one of these topics can be a presentation on their own. So there's bound to be a lot of questions, and hopefully I can synthesize all the information for you guys so it makes sense. But, this is a fairly prevalent cause of disability. As you can see, 13.5 million individuals. It's a costly issue, estimated to cost the U.S. $76.5 billion in both direct and indirect costs. And then also, people with moderate and severe TBIs oftentimes have impairments, and typically that number is somewhere between 3.2 to 5.3 million. So that's a pretty good size of the population. Some important definitions I wanted to go over in regards to, some terms you might be seeing thrown around when it comes to these injuries. One is acquired brain injury. So basically it's an injury that occurs after the brain is finished being developed. Traumatic brain injury is one of those kind of injuries. Another term is like coma. Coma is a very specific medical term, and there's certain criteria we use to consider someone in coma, but some of this includes information on EEG, which is basically like some sensors that you put on your brain to examine the brain waves, and there's different brainwave activity associated with different levels of consciousness and behaviors. And so and then there's vegetative state, which means They're not necessarily in coma, but on EEG they might be fine, but there's no meaningful response. So the two key words I bolded here is meaningful interaction and response. And as a clinician, that's where some like philosophy and neuroethics comes into play. Whether when it comes to end of life care or to prolong care with the family. Then you have persistent vegetative state. So that's typically in a trauma situation if they've been vegetative for more than 1 year. You'll sometimes hear the term locked-in syndrome. This is basically a lesion where you can move your eyes only, but you can't move, or but you can still feel. So you can communicate, but you have very little sensation. And typically this is due to strokes or other kind of lesions in a very specific part of the brain. And then you have patients that are minimally responsive who have inconsistent, meaningful responses, but they're still severely disabled. So this is just to show that I think most common reason, statistically anyways, for people having TBIs or falls. Then you have struck by an object and motor vehicle crashes. And I just kind of wanted to go over some really basic brain anatomy, just because I think when you understand the anatomy, it helps everything else make sense, and maybe it will help you interpret reports a little bit better in medical records. But our brain is divided into several different lobes. You got the frontal lobe, temporal lobe, occipital, parietal. The frontal lobe, which is at the front there in the blue, that is typically involved in like what we call higher cognitive processing. So the parietal lobe, as the green, that's more involved in like the registration of sensory information. Oftentimes people, when they get injured in this area, they'll demonstrate something called neglect, where they ignore or they lack awareness of that part of the body. You have the temporal lobe, which is on the side. And actually, this picture doesn't have a picture of it, but the temporal lobe is kind of on the side on the bottom here, and that registers auditory information, memory, consolidation, and also it's implicated in seizures. So if you then in the back you have the occipital lobe, then you have the brainstem, which is the older part of the brain. So humans have largest cortex, which is the pink kind of spongy layer, but the cortex is very primitive, and that regulates very basic functions. So things like just the cranial nerves, so the nerves that innervate our face and our senses, all the sensory information passes through that. And as you get down to like the medulla, even processes like breathing, heart rate, very, very essential life-sustaining functioning centers are located there. So injuries to those areas can be very devastating, even very small lesions. So that's just a kind of general overview on the neuroanatomy. As far as classifications of TBI, you can ask different people; they'll classify it differently. But in general, some terms you'll see here is like open versus closed injuries. Closed injury just basically means the skull remains intact. Open means that there's a disruption of the scalp and skull, which potentially you can have some outside environment contamination. An example of this is like a bullet. You can have anoxic hypoxic brain injury, which is essentially when the brain doesn't receive enough oxygen. Also happens quite a bit after people have heart attacks and they have prolonged resuscitation. Sometimes we'll get the heart rate back going, but then they'll have like pretty profound anoxic brain injury and can be in a vegetative or coma state. Then you have different vascular injuries like stroke, bleeds, aneurysms, and then you have like things like tumors and infections. But obviously, or not necessarily obviously, but for this case, probably most people are concerned about the traumatic and perhaps anoxic and vascular issues. How we grade, you guys have probably seen this before, but GCS is the most commonly used TBI severity scale. Any score between 13 and 15 is considered mild, 9 to 12 is moderate, and 8 or less is considered severe. And we use this a lot because it's simple, it's reproducible, and it's been studied for predicted value and overall prognosis. There's some flaws to it, and that's why they've also created neuroimaging scales. The one that's most common is the Marshall scale, and that's just usually used in neurotrauma centers to predict the risk of developing increased intracranial pressure accurately. But and it's it's just kind of used in conjunction with different scales like the GCS. But other considerations for the severity is like, do they have other kind of traumatic injuries that can further exacerbate the brain injury, like, for example, any associated blood loss or hypoxia or any other kind of related complications. So we have primary versus secondary brain injury. So primary, an example of a primary head injury is like a shearing injury. So shearing just means the stretching. So stretching of the nerves, sometimes at a very microscopic level, will cause something sometimes called the diffuse axonal injury. So this is like widespread shearing of the neurons, which causes inflammation at a very microscopic level and can actually, and these patients usually have very diffuse brain injury, typically are not very conscious. And this is a CAT scan, but this is typically multiple white patches throughout the entire cortex. Then you can have like focal contusions. Again, this is a CAT scan of different focal contusions where you'll have kind of localized areas of swelling and inflammation. And this is typically due to direct acceleration, deceleration injuries. And these ones also can cause profound injuries, or I should say clinical state, but it typically, compared to diffuse injuries, is not as profound. That's just a general statement there. It's not a rule. You'll probably hear of things of an injury called subarachnoid hemorrhage. This is when you have disruption of these blood vessels kind of in between the little fissures of the brain. Or sometimes you'll have some bleeding in what's called the ventricles of the brain, which can extend it to the subarachnoid space. That'll be very irritating to the brain and can sometimes cause like seizures and can be quite devastating. This is typically considered an emergency, and patients will typically present with like a very severe headache. Subdural hematomas. This is usually due to damaging of something called the bridging veins, and they tend to be crescent shaped, like in this picture, and often in the adjacent areas you'll have some injury. That's in contrast to epidural hematoma, so outside the dural space, and this is more like a lens shape. Typically, these are due to artery injuries, and the thing is with epidural hematomas is they typically carry better prognosis than the other type of hemorrhages. Mainly, these are typically with very severe kind of traumas, but they typically carry a little bit better prognosis than other epidural or hematomas. But this, again, everything I'm saying is not necessarily a rule; it's just a trend. So you can get some like vasospasms, which can lead to strokes. So this is what we're really trying to prevent in those like that first initial stabilization when the patient comes into the ICU and into the hospital. And this is where a lot of research is being conducted. And just to briefly to give you an idea of what happens in ICU, they usually come in, we do a GCS and a CT scan. We kind of see what kind of injury they had, and then usually neurosurgery is on board. We may have to monitor the intracranial pressure for some impending doom, and just in case the pressure in the brain gets too much, then have to send them to surgery. And then really we try to manage the rest of their physiology, so the hemodynamics, ventilation, if they're developing seizures, managing that. Sometimes these people can develop coagulopathies or bleeding disorders, and that needs to be managed. So while the brain heals, and to help the brain heal. Some prognosis statistics. So remember, 8 or below on the GCS is considered severe. These people typically have like around a 30% risk of death and have increased mortality for 13 years afterwards. Multiple on the good side though, multiple studies show that like 30 to 65%, as you can see there, with severe TBI will regain independence. Another note is about 5 to 15% of patients with severe TBI are typically go to the discharge from the acute care in a vegetative state. And if that's the case, if they're discharged in a vegetative state, typically only half of these patients will be conscious over the next year, and that typically carries a very poor prognosis. So some of the complications that occur. So if you think about the anatomy, as a neurologist and as a physician in general, we kind of look at the anatomy first, where the lesion is. So you often hear neurologists talk about localizing the lesion to figure out where the problem is. And usually if there's a lesion somewhere structurally, that'll manifest in very predictable deficiencies physically. So because of that, because the brain and the brainstem is the center for pretty much everything, you're going to have a wide variety of potential complications that can be related to the head injury directly. So one is, these cranial nerves can be injured. You can have problems with speaking, dizziness, balance disorders, and you can see how this spans a variety of kind of activities. It could potentially span a variety of activities of daily living and well-being. So difficult with very basic sensory functions like smell, hearing, and vision. Some people don't realize this, but so the endocrine system basically is a system that releases hormones into our body. One of the major endocrine glands in our body. Well, I guess most people think of perhaps the pancreas and insulin, but another big endocrine gland is the pituitary gland, which is in the brain, and it's very susceptible to injury because of where it's located. And injury to this area can lead to various hormonal changes like thyroid issues, growth hormone, SIADH, where you get a lot of water retention and some complications from that. So again, this can lead to brain injury can lead to a lot of downstream issues, which can lead to a whole host of systemic issues. You can have, with prolonged ventilation, you can develop a pneumonia, pulmonary embolus. Cardiovascular wise, these people that are bedridden for a long time can sometimes get DVTs. There's a kind of a unique phenomenon to head injuries, which happens sometimes called central storming, where you get abnormal stimulant response into the blood, causing like fevers, high heart rate, sorry for that misspelling, high blood pressure. And then you can have spasticity. So I put a picture there of kind of like how the wiring essentially from our brain down to our spinal cord. So in the red track there, that's the upper motor neurons, and that's how it kind of travels across up the spinal cord into the brain. And that's why you can see like a right-sided lesion in the brain will cause a left-sided lesion in the body sometimes. And so any injury along that path in the brainstem or in the brain can cause weakness. And the difference is when it's in the brain or the spinal cord and above the injury, this weakness is typically with marked spasticity, which is a velocity-dependent increase in tone. So in other words, they might feel fine, but when they start moving, they start catching, and makes it very hard to move, and they'll have contractures. Oftentimes after a stroke, you'll see people kind of with their hands curled up and their legs sticking out, very spastic, and that can cause a significant amount of disability and discomfort as well. And then I think we have a neuropsychologist next, but he can talk to you more about like the cognitive problems that can occur. So there's just as you can see, my point with these slides were kind of to show that how a brain injury can lead to so many other kind of disabilities to consider. And, I think my suspicion is, in the legal sense, is to sometimes tie in some of these patients' disabilities to that original insult. And so, you need to have someone that's aware of how everything can be related. As far as recovery is concerned, it's so variable. This is a kind of scale some people use at Rancho's Los Amigos scale, which you don't have to. Basically, level 1's the worst, up to level 8. You don't have to. People don't necessarily recover in sequence, but it's just, for us, it's a decent estimate for recovery. But the main reason I think, at least we used to use it, is some families just find it comforting to know that, like, for example, that confused, agitated response, for example, if that patient's in that level, that'll be really alarming to loved ones sometimes, and even to other involved parties. And so that can help kind of comfort people to know that, okay, that's within the normal scale of improvement. As far as, so we talked about the long-term complications, long-term impairments, very similar. So any kind of injury to the motor cortex or pathways are called weakness. We talked about spasticity. This can sometimes require things like Botox to improve that spasticity, or sometimes we do like intrathecal baclofen pumps into the spinal cord itself. Tons of behavioral issues that I'm sure will be addressed in the next talk, and as well as cognitive issues. And then, in general, these patients tend to just age faster for various reasons. I mean, it's harder to lead a direction towards health or a healthy lifestyle when you have profound disability. And there's a lot of psychological factors that go into that as well. But that's just something to consider as well. And I hope these are some of the sources for the slides later. And again, you can contact me for any other questions, but I hope I did a decent job of explaining how a brain injury, even if it's like a small little injury in the brainstem, can lead to a whole host of issues that we have to kind of consider long-term as we plan for their life care planning.
Thank you, Dr. Kavishwar. Yeah, I was enthralled by your slides. It was a lot of great information. Dr. McDonough, are you prepared to share your slides with us?
I think I am, yes.
Perfect.
Yeah, there we go. Do you see them?
Not yet.
All right, let me hit share screen again.
Mm-hmm.
All right. And all righty. So I figure that most of the folks attending today are well aware of what the cognitive, the neuropsychological, some of the psychological issues are after brain injury. What I'm going to focus on more is how I interface with the life care planner so that we have fluid communication and connection. As our moderator said earlier, it's good for all these parts to speak together. And I think we get a sense of that from this little picture that we have up there. Different things, there's lots of factors. It's not a simple decision tree, but rather there's lots of complexities in this. And so that's what I'll try and speak about as we go through here. Let me see if I can move my slide down. Okay, there we go. The information we have, slides are available. This is the contact information. I did not update my bio here, so I no longer have an office at Children's Hospital, and I stopped paying scripts rent. So this is the new location. If you want slides and can't get them from the group, then by all means, just email me. We'll be happy to send them to you. In terms of the life care plan, the neuropsych evaluation, it serves to quantify what are reasonably expected residual deficits based on the testing. And when it comes to purposes of the life care plan, we're talking about two things: deficits which are created by the trauma, as well as deficits that could be made worse by the trauma. And I think that's an important consideration when we talk about what we see or what we don't see in patients. years back, I had a go at Lifecare planning. I realized shortly thereafter it was not my thing, but I did read a lot of the work of Paul Deutsch, and I think he's an excellent source for that, plus the other speakers as well. The notion is that it's not funding based, it's needs based. So if I recommend 5 neuropsychological evaluations or 2 years of therapy or cognitive remediation for a patient, I'm not beholden to what an insurance company will allow. Typically, when you talk about therapy, allow once a week. That's not written in stone. Some patients need therapy 2 times a week. And so, without regard to what the funding is, and with regard to what the patient's needs are, is how I communicate with the Lifecare planner. My next bottom note there, understand the Lifecare plan, keep notes of recommendations, and communications with other providers. When I speak with a Lifecare planner, they call up, they ask what services are needed. I'm always sure that I document my conversation. 99.9% of the time, what I said is what goes into the Lifecare plan. But you always want to be sure of that. I don't want to be surprised in trial or deposition by something that's inconsistent or if I've been misquoted or misunderstood. The little abbreviation down there, NJNY, before coming back to California about 20 some years ago, I practiced in the New Jersey, New York area. And I did have a Lifecare planner who had a quick call with me, preemptory, not to be solidified at that point, but it was solidified. And they had gone forth with a 7-8 figure estimation, which was not consistent with what the data I had was. And so our conversation, while it was somewhat extemporaneous, was taken as what the needs were. We can avoid that by having good communication with the other treaters and certainly with the Lifecare planner to make sure everyone's on the same page there. The supportive documentation is of immense importance, as you know. The medical records, academic records, vocational records. I'm always impressed by the amount of records a defense-oriented evaluation can get, which is not always commensurate sometimes to a plaintiff-oriented evaluation. And so when asked what records I want anything that is relevant in terms of vocation, education, and medical history, both pre and post. And I want anything that my adversary has. I want to be able to have privy to review that as well. When I make the recommendations for the Lifecare planner, it's my understanding that many times they go through and use this outline that I have here, or something akin to this. What is the purpose of the evaluation, or the recommendation, rather? What is the purpose of continuing this or starting that? What is the time frame? Over what period of time is it valuable? There's not a lot of point in 50 years of individual therapy, unless it's palliative, and even at that, one could argue it's over the top. So the time frame, I think, is relevant to express in terms of repeat evaluations. And at some level, maybe we want to titrate the service. And I'll give you a schedule and a slide later on that I often use with, as an example, with therapy. I don't want to start somebody with therapy twice a week and continue twice a week and then stop suddenly. Rather, we want to do a titrated measure so that ideally, as the patient might be getting better or better adjusted psychologically, then services pull back a little bit. It's like a least restrictive environment in academic settings. You want the person, the child or the student or the patient, adult in this case, to be able to rely on those services that are there for them, but also to be able to separate from them when it might be appropriate with a safety net. And I'll talk about that safety net. Next is the frequency. How often? Is it 3 times a week? Is it once a week? Is it once a year? The cost. Sometimes I'm asked to estimate the costs. I do feel that the Lifecare planners, the economists, are probably better able to estimate the costs. I know the cost for what I do. But there is a range there. And while I'll certainly weigh in on that, this is my experience. Ultimately, I think it's better addressed by the life care planner or the economist. They factor in the things that I would not. The fifth bullet down, resources. That would be if I'm asked to provide a recommendation for where this service might be provided. So if I'm looking at driving, if someone is unsafe to drive, but we might want to recommend they see a driving clinic. There's one at Scripps, there's one at Sharp. And so the resources would speak to that. So when I'm finished speaking with the life care planner, I've outlined, and I will go in greater depth on this, but on the surface, I've outlined what the neuropsychological issues are that require attention, ongoing attention, and what the psychological issues are that require ongoing attention. Documentation of those issues, that's already in the neuropsych eval. So that's where the data is. One thing I think that's a relevant consideration from a neuropsych perspective as we interface with life care planners is the time since injury. There is a period of what's called spontaneous recovery where the brain starts to improve. If I have a patient who is 1 year post-injury, there's still potential for improvement at that time versus someone who was 4 years post-injury. And ideally, in my experience, most of the life care plans, with some exception that I've worked on with others, the person is past that period. They're at the point where the deficits that we see on testing are in all reasonable probability permanent deficits, and that way we can speak to those recommendations with more assurance. It's based on the injury severity. The more severe injuries require more follow-up. And Dr. Hirsch spoke earlier about different ways of assessing brain injury or TBI. We have Glasgow-Coma scale, retrograde and anterograde amnesia. The type and location of injury has an effect on how a person does and what their needs are. These are the kind of most prominent two classifications for head injuries. I believe at one point there were well over a dozen, but these have come to the forefront. And then the Glasgow-Coma, you saw, of course, on an earlier slide. But here's what I want to say. These are measures of the severity of the injury shortly after the time of injury. And I think I know I've seen, and I think attorneys have probably dealt with patients who come to them with an initial Glasgow that is very impaired, but their functional testing may not be. That functional testing is what is more relevant at the time of the life care plan and at the time of trial. Conversely, we've had people with reasonably good Glasgow-Coma scales who have severe injuries. And so it's a good measure of the severity at the time of the incident or shortly thereafter, but it is not always a template for where that patient's going to be 1 year, 2 year, 4 years down the road. And that's where the neuropsych has better application and is what we use in the life care plan. Now I say there's a caveat on the bottom of that one, absent seizure disorder or unseen complications. So I can have a patient whose testing looks perhaps mildly impaired, but if there's a progressive seizure disorder and it's not well treated, that mildly impaired performances have the potential to get worse over time. So I'm going to do the neuropsych and psych recommendations separately, but I do want to talk about some of the range that a neuropsychologist can have in speaking with the life care planners. Obviously, we're talking about the cognitive and emotional needs based on the data that we have that validates those problems. But there are also other areas too, and that I will frequently discuss with the care planner. Sometimes the care planner will bring in other docs to reinforce that thought, or I may reinforce a similar thought from another doc. And one is medications. As a neuropsychologist, I don't prescribe, but I can make reference to that or recommendation to a medication, defer to the prescribing physician. And so if I have a patient who has problems with attention and concentration, those problems are physiologically drawn, medications might be appropriate. Frontal lobe disinhibition, there are some medications that might be appropriate. And so that's just kind of a peripheral area that the neuropsychologist can speak to and get support from the other treating docs that have particular expertise in that. The next is vocational. And the question usually is, can someone return to work? In what capacity? How many hours a week? What type of job? Can they do their prior job, etc.? It always kind of humored me when I would get someone who was a patient who had a moderate to severe brain injury, and they were a high-level executive. And the other side would say, well, they can work. They can be a greeter at Walmart, or they can flip burgers or something. Perhaps, but it's not commensurate to what they had before, and it's an accommodated vocational position. DOR, there is an abbreviation for the Department of Rehab. Many times I will have patients go and see them for some work training, maybe some symbolic work, something to improve a patient's self-esteem, get them out of the house, but not with the intent of necessarily being full-time employment. Educational issues is fueled by what the neuropsych limitations are, or limited by them rather, and whether or not a patient can go back to school. What if they do go back to school? What would be a reasonable load? What would be a reasonable schedule? And certainly have weighed in on that based on the data. The next one down, we need a couple of commas in there. So we have drive, comma, finances, competency, and ability to self-medicate. I'm often asked whether a patient can drive, if they're safe. The standard for concern about that, I think, is somewhat low. Patients can be potentially lose their driving privileges by being on particular medications. They could have good attention, they've got a good executive functioning, but if they're on a particular medication, maybe for memory, they may lose their privilege. When I look at driving competency and speak to a Lifecare planner about that, I'm looking to see support for that as a concern based on the neuropsych data in areas of attention, executive functioning, processing speed, and memory. And if those or some aggregate of those are impaired, driving may not be a feasible notion, and having a driver or an account for Uber or Lyft might be a reasonable substitution to put into the costs. Competency is, as the name implies, is the person competent to make their own medical decisions based on what we're seeing here. Do they need a fiduciary? Do they need other professionals to help them with their finances, with their medical decision-making, etc.? And then the third one there, ability, or fourth one down, ability to self-medicate. Many times patients with brain injury know they need to take their medications, but may not take their medications because of memory problems or emotional issues, acting out, refusing to acknowledge their limitations, or executive dysfunction. And so that also is a consideration. And it's not as easily solved just by getting a pill container. It might be that a visiting nurse needs to come in and administer the medications, validate that the medications have been taken, etc. On some patients, smell is an issue. And typically with more frontal-based injuries, where the occipital bulbs about an inch back from the nostrils are crushed, patients will lose their sense of smell. That's more than an inconvenience. If you're in a home that has a gas stove and you can't smell that gas, if it's leaking or if it's on, that's a problem. And so it becomes a safety concern. Switching to an electric stove, various permutations, various interventions can help address and compensate for that. So when it comes to the neuropsych, and I'm speaking to a Lifecare planner about the neuropsych issues, One thing we typically talk about is the scheduling of the neuropsych reevals. Those really vary depending on the particular dynamics of the patient and their age and what the demands in their life are. If I have a child, neuropsych evals are going to be probably every 2 years and then titrated thereafter into adulthood. That being because a child, as we go through the elementary years into junior high and high school, the demands change and the development of the brain may not have kept pace with their peers. They may still be gaining and doing better than they had the year before, but if they're going at a slower trajectory than their peers are, then the neuropsych eval is going to be important, not only in terms of understanding and helping them academically, but in other arenas as well. So when we talk about the neuropsych reevals, the question I like to, or the answer I like to have to the question is, when do we do it? Why do we do it? What's the justification for doing it every 2 years or every 3 years, titrating to once every 5 years? And that has to have a logic behind it. I don't think it's judicious to recommend a neuropsych eval every 2 years until the person's 80. There's no functional reason for that. So any recommendation, I think, has to have a justification behind it that's articulated to the Lifecare planner. We do the same with cognitive remediation. Whether or not the person is past that point of recovery is somewhat of a moot point. Cognitive remediation can have a palliative effect. It can help keep the person going. It can help accommodate deficits that are not going to change. And so it still has value even after the 4-year period or when deficits are permanent. The example I always give about the difference between direct rehabilitation and accommodation is to think about physical therapy for a broken leg. You break a leg, the direct rehabilitation effort is physical therapy. And we're going to work the leg, we're going to strengthen it, increase the range, etc. Past a certain point, if the physical therapy doesn't work, someone may need a cane. That cane is an accommodation. It doesn't improve the actual functioning of the leg, it compensates for it. And so we think about interventions, whether they're neuropsych or psych or cognitive remediation, in that vein, in terms of, is it accommodation, is it rehabilitation, or is it somewhat of a palliative type intervention to keep the person from falling further behind? In regard to psych, typically the questions with psych when I meet with a Lifecare planner are, do they need therapy? How much therapy do they need? How long do they need it? Do they need inpatient or outpatient? And let's go with those first. The issue of psych with traumatic brain injury is important because people with TBI are more prone to have psych issues regardless of whether or not they had a prior psychiatric history. If they had a prior psychiatric history, they're at greater risk post-injury. If they didn't have a psychiatric history, they are still at greater risk post-injury than if they didn't have the TBI. And at the end of the slides here, I have a couple of references for you that speak to that, to speak to those needs and those changes. All right. The projected needs for therapy are not as simple as just going into therapy and having the work done. People's responsiveness and acceptance of therapy varies on a number of factors. That includes their premorbid state. I had a patient who was in a motorcycle accident and lost a leg. He was a macho guy. He was a tough guy and not one to want to talk about things in therapy. His therapy was alcohol after the injury. And so those are factors that need to be considered in his therapy efforts. The loss of the leg, other orthopedic residuals or limitations apply another layer of complexity onto the therapy for a post-TBI patient. Depression is common, anxiety is common, but they're not the only factors that fuel the emotional issues for a client. Bottom third one down there talks about emotional lability and disinhibition, particularly with patients who have had frontal lobe injuries. Disinhibition is very much a problem. People will say what's on their mind without censor. They will do things without censor because it felt good at the time or felt appropriate at the time. This is in patients for whom that is a prominent issue, need to have some scaffolding around them to prevent them from themselves, so that when they go into society or when they're at some social setting, that these issues are not becoming a keystone for others having problems with this person, or law enforcement having problem with this person, etc. It's within the realm of psych, but it's one of the many facets of needs that we see to be addressed with individual therapy.
Dr. McDonough, I know we're running a little bit off schedule, but so is there a way you can give us a big takeaway?
I certainly can. Yes, indeed.
Thank you.
Here's a rough therapy schedule that I might use with a Lifecare planner. Start out twice a week for a year. I say, remember, it's needs-based. The once a week therapy model is an insurance-based model. It's not necessarily what a patient needs. And you see by this chart here that basically what I've done is titrate that over time. I do like to have inserted in there opportunity for future sessions. If need be, people have relapses in one form or another. So on this slide, I have 30 to 50, arbitrary for the point of illustration, future sessions. And therapy does not always involve just the patient. It could be a family, it could be a couple's issue, or others within the family that directly or indirectly also have needs. Oh, and that was fast. So here are those. Here's the slide, the references to the different articles that speak about some of the psych issues. I was very responsive to your request to speed it up.
I see that. Thank you so much.
Yeah, thank you.
All right. And then, Brooke, are you ready to share your slides with us?
Sure. Yes, I am.
Thank you so much.
Okay. And okay. Good afternoon. I'm a Lifecare planner here in San Diego and all over, actually. I'm a registered nurse and a certified case manager as well. My practice is split between case management and Lifecare planning. So I'm actually working within the field at the same time. So I'm very familiar with current treatments, what's going on. And Dr. McDonough, I want to follow you someday. You and I need to share a case. That's great. My big priority is communication. I feel like we all need to communicate, retaining attorney as often as is necessary, and also with the providers. And if I am not given that information, I certainly ask for it. I think it's extremely important, as the other presenters have said, is to make sure we all collaborate as a team for the best possible outcome for the injured person. I'll just kind of start. One of my most frequently asked questions is, do I need a Lifecare plan? I get calls frequently from attorneys who aren't sure. They have somebody who's injured. So what I try to assess is, how many areas of involvement are we talking about? Is it a multiple trauma? Is it a brain injury? Is it a spinal cord injury? Sometimes it's an inadvertent colostomy, or sometimes it's fractures that just aren't healing right. So we kind of talk about what's really going on. Are there complex future medical care needs? Is their ability or mobility impaired? Future surgery, or complex medication, home care, DME needs. So these are the kind of things I talk about with a referring attorney to see, if this is going to help the case. We frequently decide on things that people might not think a Lifecare plan could come from. So what I talk about is, look, we have the Lifecare plan, which is the full-fledged, what we've been talking about today. That's a full-fledged report with multiple different areas of need. And I'll just kind of share one of my redacted reports with you and just kind of show you how that lays out. It's the best way to document future medical care costs and needs. And as an RN, I know I have colleagues that are not nurses. I have experience and I am a case manager. So it's very, very important because sometimes you can bring something to the attention of the provider and say, well, I've noticed this is going on in the house. How do you feel about this type of intervention? Now, I know opposing attorneys have a lot of fun with me in depositions about that, but, did you bring that up to the doctor? And I said, yes, I did. But I think it's important because as a medical team, we collaborate. And it's all about collaboration in a good life care plan presentation. I also do cost projections. This is a field that's growing in life care planning quite significantly. And it's where, for instance, you might have a spinal surgeon who says you have an adjacent level fusion needed, or you might have somebody who's had a total knee who needs another total knee 20 years down the road. Something like that, where it's a very specific need and you just need a cost. And so I'll prepare that report and include, be very global about physician visits, therapies, medications. And, you don't have a whole lot in there. You've got maybe 5 or 6 tables, but it gives you a document where you can justify the demand. And I'm doing quite a few of those. We have to be careful not to use a cost projection when it's complex and it actually needs a life care plan. So we'll talk about that as the case develops. If I do the record review and I find out there's a lot happening there, I will call back and say, you know what, this really needs to be a full-fledged life care plan, or I'll discuss that with the provider, the identified doctor or physician involved. A cost projection, like I said, you just need more of an estimate. The MD has written a clear report with very specific future needs. Needs are not comprehensive. The client interview is optional. But what this will provide is the detail to justify your demand or your future medical needs. And then the life care plan, like I said, more complex home situation. A client interview is required. I like to go with the physiatrist if that's at all possible. We go together. We spend a lot of time with the client. We're doing a multifaceted interview. We're talking to the family. Of course, COVID has messed us up a little bit. I'm now vaccinated, and so I know 2 of the physiatrists I work with are vaccinated also. People still aren't super comfortable going into the home. We do Zoom meetings, sometimes telephone because the client isn't capable of putting together a video, whatever happens there. But definitely you want that interview. You want eyes on, you want to see what's going on. You want to look at that house. Do we need more mods? Things like that. You find things in an interview that you would not find otherwise, 100%. And then a trend I'm seeing maybe a little more often too is that the doctors are saying, okay, yeah, he needs this adjacent level fusion. It's going to cost, $240 globally. Now I'm careful about that because, and they'll send that to me to put into my life care plan. I always cost everything out myself. I will get the codes from the providers. And like Dr. McDonough said, sometimes, they want him to cost it out and he knows what he charges. And a lot of times that's the perspective of the medical provider coming forward, is they're saying, okay, this is what I charge. But you have to be careful about that. You have to be neutral. It has to be, you don't know that provider is going to be there when that patient needs that surgery. So I cost it out for the geographic region. Also, a life care planner is an expert in costing and analysis. So they're going to analyze we are going to analyze the recommendations and justify that. We use a comprehensive approach, making sure that nothing's going to be forgotten. Maybe did they forget to put in the therapy or the DME that they need at the time? The DME is a huge one. They're expensive. The shoulder braces or the AFOs, KAFOs, whatever you need for a surgery, you got to make sure you include everything. We need a complete picture of all the rehab needs. And, it's not my job to say what is needed. It's the provider's job to justify that. So we work together as a team and come up with that together. Let's see. And then in testimony, we remain neutral. Plaintiff or defense, the plans should not change. I know that's not always the case, but your recommendations, your costing should be the same on both sides of the fence. 75th percentile, 50th percentile, whatever you're using should be unbiased. And you need to be able to show your consistent methodology across the board, and your numbers are supported by that. And then you rely on as a nurse, I do often rely on my skills, training, experience, and knowledge, and that goes forward in deposition pretty cleanly. I'm always challenged in it, but I feel confident and able to defend it. I'm just going to quickly, I know we're short, we're running behind, but I did want to just share with you super quickly. This is a redacted Lifecare plan of mine. So this is the full plan. You see it's in table format. Can you see it?
No.
You'll see your slideshow.
Okay, sorry. Let me pop this up on another screen. Sorry. Here we go. Okay, there we go. So this is, it's just a table that I have here. I do a brief introduction. I don't do, and I think a lot of my colleagues are moving away from doing vast amounts of narrative. You've got that nauseum across the board through all your providers, and it's a real open window for a lot of mistakes. They could say, oh, well, Dr. So-and-so said this, why are you saying that? And I'll tell you, never challenged on. I got rid of my narrative a long time ago, and it's very basic. I have my life expectancy, client interview details, and just what is a Lifecare plan. And then I have a table that summarizes everything. These are the different categories that I show. This is the life expectancy is in the middle. And these are the costs. I have one-time costs, which are fixed, and then recurring costs, which are annual. So you'll see that I've got a physician table. And so this you can see, if you're presenting a document like this with a demand or for, to the group, any Lifecare plan is going to be extremely valuable to you. And then I just also wanted to show you the quick cost projection, what I'm doing there. So this is just the same sort of format, right? It's a lot less involved. There's maybe, there's definitely fewer tables. But you can see that when you're coming down to it, we have an arthroscopic revision of a rotator cuff repair. That's a complex surgery, outpatient. So we've costed that out along with the therapies, the doctors, labs, pre-op medical clearance, that kind of thing. So with that being said, I don't mean to rush all the way through, try and catch up a little on time, but I just wanted to show you what I do and to let you know that for Lifecare planning, it's valuable in many different arenas for you. So thank you very much. That's my presentation.
Perfect. Thank you so much, Brooke. And then I believe we have Eliana next, who's going to share with us about her hospice and rehabilitation therapies care. Eliana, are you with us?
Yeah, I'm right here. Can you hear me?
Perfect.
Okay, cool. I'll just share my screen. Okay, so thank you for the opportunity for allowing me to share about the facilities. My name's Eliana, and I own a facility in San Diego that's licensed to provide care to spinal cord injury patients, brain injury patients, and patients that require both acute and subacute care. So there are 4 different types of facilities that your clients are able to receive care in after an accident. So we've got acute care hospitals, long-term acute care hospitals, skilled nursing facilities, and congregate living health facilities. So I'm just going to dive into these as they relate to personal injury patients and workers' comp patients. So we all know what a hospital is, but I'll just dive into what it really is and how it relates to personal injury and workers' comp patients. So say you have a severe injury that requires short-term treatment, like a head injury, for example, or loss of a limb, or spinal cord injury, or another urgent medical injury. So these patients, they really need immediate care at the highest level. So since acute care hospitals provide the highest level of care, such as to brain injury patients and spinal cord injury patients and amputee patients, these acute care hospitals are going to be the most expensive. And then the types of care that these patients may need, and that's what acute care hospitals provide, they include providing an emergency department, intensive care, or coronary care, or cardiology, or neonatal intensive care, surgeries, and other additional services that aim to make a patient more stable, so then that way they can step down to a lower level of care. And in these facilities, that's their primary goal, to get patients transferred out of an acute care hospital and into a lower level of care. So next, we'll get into long-term acute care hospitals, and that's one of the options for stepping down after being discharged from this type. So in long-term acute care hospitals, these patients, they have a little more stability, and these facilities, they can still provide ventilators and multiple IVs, and they can also do cardiac or brain monitoring. So this would really come into play, such as if a head injury patient needs a lot of therapy, but say they don't need to be in an acute care setting. And now it would also come into play if, say, an amputee patient who needs a lot of therapy, but doesn't require an acute care setting, and same as for head injury patients that need brain monitoring, speech therapy, or occupational therapy and physical therapy. So basically, in summary, LTACs, they want to wean patients off of trachs, but patients still need therapies, such as occupational therapy or speech therapy or physical therapy. So basically, it's a lower level of care than acute care hospitals, but higher than skilled nursing facilities, and that's what we'll get into next. So skilled nursing facilities, they are a step down from a long-term acute care hospital, and therefore they are less costly. Hang on. Okay, yes. So services that are provided in SNFs, they include meals, skilled nursing care, physical therapy, occupational therapy, speech therapy, medical social services, medication, ambulance transportation, and dietary counseling and medical supplies that can be used in the facility too. So say the head injury patient may go there for more therapy, maybe to improve their activities of daily living, or the amputee patient may need physical therapy activities for daily living and maybe learning to adapt to their prosthetic device, for example. Another example would be if a patient's wound is now closed and they need help with dressing it, or perhaps a patient needs help transferring from a seat to the shower, or getting from the wheelchair to the couch, and other activities of daily living like these. So I guess the one problem of putting personal injury and workers' comp patients into skilled nursing facilities is that in SNFs, they have such a high risk of infection, since there's no separation between patients injured in trauma and patients with various disease progressions. But thankfully, there are specifically tailored facilities that work for injured patients. And these are congregate living health facilities. So these congregate facilities, they're really changing the opportunities that are available for personal injury and workers' comp patients. So these types of facilities, such as Coastal Injury Care Center, they provide the solutions for attorneys and surgeons on where, say, TBI and spinal cord injury patients will go after undergoing complex surgeries. So in CLIFs, the abbreviation for them, the surgeons can continue to follow their patients. And additionally, there's no limitation on the coordination of specialty services. So, for example, that head injury patient can go from an acute care setting directly to a congregate living health facility and then stay there until discharge. So they don't need to keep stepping down. And then in this setting, the staff gets to know the patient very well, because the patient's not just bouncing from facility to facility. And then also in CLIFs, such as Coastal, the head injury patient can have brain monitoring, intense therapies, and activities of daily living without, continuing to being shuffled, like I said. So here in these smaller facilities, patients have a lower risk of infection because congregates, they don't have a large volume of varying patients with different disease processes. So in these facilities, the amputee patient gets stable, they come directly to a congregate, and they get all their dressing changes here. And then the patient can get everything they need here, including physical, psychological, and medical aspects entailed in recovery, and then all in one place without moving from building to building. And then lastly, so some of the congregate living health facilities, such as Coastal Injury Care Center, we are able to work with attorneys on a lien basis and provide extensive documentation to attorneys that is needed to optimize case settlement. Thank you, and feel free to let me know if you have any questions.
Perfect. And then I believe next we have Marjorie from Sage Settlement Consulting.
Thank you. And let's see, I'll share my screen and hope that I'll have, there we go. Thanks. I'm glad that my part comes last because I imagine you are saturated with all the technical and great information from everybody who spoke before me. And I want to save time for questions for all of them too. So I'm going to kind of breeze through my part and then invite anybody who would like for me to elaborate on any of these points to call me or email me directly. But where I come in is after the attorney and after the medical professionals and the life care planners have done their work, and you all have obtained the best possible monetary compensation for what this claimant has suffered, when you've got the biggest number that can be gotten, what do you do with it? Well, that's when I step in and I work with it. Because it may not be fair, but you all are also responsible for a lot of other things. So we can't relax or call it a day just yet. You still have some tasks to attend to before you can finalize the settlement and secure funding for your claimant and for yourself. So that's when you may want to consider, and when I recommend that you consider engaging a settlement planner to help you kind of work on a parallel track. While you're resolving liens, doing final accounting, you probably have to file for court approval if you've got a client who's traumatically brain injured. My suggestion is that you work on all that and then you hand your client and the client's family, if that's the case, over to a settlement planner who can iron out a bunch of issues as you're doing everything that you need to do. And then you can come back together and file for court approval if that's what you need to do, or finalize a settlement agreement. But you'll make sure that your client has received what is a complimentary settlement consultation that I have to imagine is appropriate in a case where you have someone who's been traumatically brain injured. So yeah, I mean, even though your main job is to get the money for the client, you're actually responsible for all other kinds of stuff. Unfairly though that may be, you have to think about, does Medicare have a future interest here? And if so, how do I account for that? Do I have to think about protecting a client's government benefits, and which ones could be compromised by a settlement? A settlement planner can handle that stuff for you and then provide documentation that you did have somebody qualified and certified. I'm a certified structured settlement consultant, but I'm also a series licensed financial advisor and a certified financial planner. So I have a fiduciary duty to your client to put the client's best interest first and to take care of all kinds of financial issues related to the settlement to help you get court approval. And basically, and this is why I was invited to speak, to help fund the life care plan and all this future care that you all have projected for the client. And often we do that with a structured settlement, and there are many benefits of a structure. I really won't get into it here, but I'm going to mention a couple of neat points because the one about protecting against Medi-Cal recovery, it's not really related to what we've been talking about today, but I still think it's worth mentioning. Only in California can you use an annuity to protect against Medi-Cal recovery. So if you have a client, to put it bluntly, whose days are numbered, and that person's been on Medi-Cal, and the family is concerned about what happens to the settlement should this claimant die, one thing that can make everybody feel more comfortable is a structured settlement. If structured settlement's paying to a client, if that client dies, payments immediately stop and they're protected in the annuity and they go towards beneficiaries. If the client instead had received a cash lump sum settlement, then upon death, that client, everything they have is subject for Medi-Cal to come in and take it. Only in California can you do that with a structured settlement, nowhere else in the country. So I just wanted to mention it. And please forgive me for speaking in stark terms, but you all are attorneys and we have doctors here. And so we're all used to looking at things through that lens of being kind of technical. So anyway, also on these physical injury cases, funds grow tax-free in a structure. So that's something else to mention. It can really maximize the money that you all have all worked so hard to obtain. And then my final point, and again, I'll turn it over to questions. something I want to mention that a lot of you may not know. Most people are familiar with the traditional fixed annuity that provides guaranteed tax-free income in whatever kind of plan you design. It's funded with an insurance policy. It's an annuity. And that's great because there's nothing to worry about. You know exactly what you're going to get and when, but you are locked in at current interest rates. And since there's virtually no risk, you know, you don't have the chance to grow funds as much as you would were you investing in the market. And so we do have a couple of options that can sometimes help clients get more quickly to where they want to be as far as, you know, what the overall return is. A fixed indexed annuity is really neat, and we use those for cases that require court approval. So they do guarantee the return of principal, but they have the chance for payments to grow if the market does well. So there are a few different ways we can do indexed annuities for brain injured clients. The last one, the fancy Mercedes sports car product here may not be appropriate for someone who has been brain injured and cannot afford to incur any risk. However, if we think that maybe it's appropriate, you can have funds structured while they're invested in the market. So there's no guaranteed return there, and judges could raise eyebrows at that if we have someone who's brain injured. But a lot of people want to invest in the market anyway, even if it's through a trust. So it can be a solution, especially when it's combined with an annuity, and you can have a trust company manage the account. You could have a financial advisor manage the account. You get tax-free market-related returns. It can grow a settlement exponentially. So anyway, I'm happy to talk anytime about all of this stuff. And thank you all for listening and for letting me participate. And I'll turn it back over to our panelists for questions once I figure out how to stop sharing my screen. There.
Right. Well, thank you so much. And yes, if anyone has any questions at this time, we'd love to hear from you. I'll just wait a couple seconds to see if anyone has anything for our panel today. Thank you again, all of you, for your wonderful presentations. That was just so densely it's so great. I love the information today. If anyone has questions or wants any copy of the presentation materials today, you can, of course, email events@injuryinstitute.com. We'd be happy to provide that for you. All right. Well, thank you again to our panel, our wonderful panel, to Robert, our amazing attorney, and everyone else, and from Injury Institute and San Diego Injury Network. Thank you for joining us. We hope you have a great day. So take care, everyone.
Take care.
Have a good one. Bye.